Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hassaballa.
All right. Thanks for coming, guys. This is be a chalk talk about a case presentation. So we're gonna go ahead and get started with the case. So this is a 35-year-old woman. Her past medical history is consistent with anxiety, anemia, SVT, and she had an ablation in the past, interstitial lung disease, Raynaud's disease, mixed connective tissue disease, GERD, and hypertension. Just to let you know, she was taking mycophenolate, which is like an immunosuppressive drug, and hydroxychloroquine. She went to the ED complaining of generalized body aches, low energy, multiple episodes of vomitings for several days. And now she had a lot of diarrhea, a non-bloody, watery diarrhea with some lower abdominal cramping. Here were her initial vital signs. Temperature was normal thermic, 96.5, tachycardic at 119, breathing quickly at 24, and blood pressure 97/68. She was in acute distress. Her abdomen was not tender and was tachycardic on physical examination. So right off the bat, look at that blood pressure, 97/68. What does that suggest to you?
Pulse pressure is really narrow.
The pulse pressure is really narrow. So what does that mean? What could that be?
Sepsis. Positive.
No, sepsis is the other thing. It's a wide pulse pressure. So you have a low diastolic. This is a relatively high diastolic blood pressure. So that indicates either volume contraction, volume depletion, or cardiogenic shock can be like that, or PE can be like that. So a narrow pulse pressure in somebody who comes in with vomiting and diarrhea, that's very good. Will tell you that they're probably dry, intravascularly dry, just by looking at that blood pressure. Her serum creatinine was elevated at 2.73. The lactate initially was 6.9 and then went down to 5.8. Her PTT was elevated at 68. She's not an anticoagulation as far as I know. Her platelets were low at 120,000. Her initial hemoglobin was 13 and it went down to 10.5, and the initial WBC was normal. C. diff was negative, viral panel was negative. Her urinalysis showed moderate protein, marked amount of blood, positive nitrates, large leukocyte esterase, 10 to 20 WBCs, 10 to 20 hyaline casts, 1 to 3 granular casts, and marked bacteria. So, just what do you think? Could be the diagnosis here. Diarrhea, vomiting, she has a UTI, hypotensive, tachycardic. Sepsis, yes, sepsis definitely. I mean, you could have sepsis and be volume depleted.
Mm-hmm.
I mean, then you replete the volume, and then you get vasodilatation and then everything like that. So yeah, I mean, definitely sepsis is definitely on the differential. Anything else? Kind of. I think sepsis is a really good guess. Absolutely. So, she was admitted to the floor. They started her on IV ceftriaxone and doxycycline. They started saline at 150 ml per hour. She progressively became more and more short of breath and tachycardic, much more work of breathing. Lactate increased to 7.4, so they called the rapid response, if I remember, and they transferred her to the ICU. She continued to complain of shortness of breath, and then they got a chest X-ray and it showed diffuse pulmonary edema. They put her on non-invasive mechanical ventilation, and then suddenly, unfortunately, she became unresponsive, and they called the code blue, and the rhythm was PEA. Remember, PEA are the.
This was emitting nurse. Yeah.
Oh, you were the emitting nurse. So PEA is H's and T's, right? Hypoxia, hypotension, tension pneumothorax, hypothermia, all those things. So 7-minute code, and then they had return of spontaneous circulation. She then went into shock. Norepinephrine was titrated to the maximum dose, and they added on vasopressin. Then she unfortunately suffered another cardiac arrest. After 5 minutes, had return of spontaneous circulation. The lactic is now 17. They started her on she was started on bicarbonate. Her legs and arms were diffusely mottled. The intensivist that night placed a PA catheter. The initial CVP was about 7 to 10. Pulmonary pressure was 32/20. and the temperature was 105.9. We were able to get imaging. CT the chest showed diffuse pulmonary infiltrates, looked like ARDS. CT abdomen shows possible pyelonephritis, not much else. She was so febrile that the intensivist decided to put a intravascular cooling catheter to maintain normothermia, not hypothermia. Repeat ABG showed a pH of 7.1, had another cardiac arrest, PEA, and then had return of spontaneous circulation. Now is on maximum dose of norepinephrine, epinephrine, vasopressin, and phenylephrine. The intensivist reached out to cardiology, not an Impella candidate, coxsackie surgery, not an ECMO candidate, arrested again, and then the family requested no more resuscitation, and the patient passed away, unfortunately. I know you know. Any idea? Oh, you know too? Any idea what I mean?
I will say we had no idea.
Yeah, how was that determined?
Blood cultures.
Yeah.
Okay.
But yeah, during all of this, we had absolutely no idea.
No clue what was
No
what was
clue.
happening.
And
she
her
just
belly was like so distended, so we did, and she vomited
A ton.
like 2
Yeah.
liters when we were trying to intubate her. So we were like, is this some sort of like,
Abdominal
like
situation?
small bowel, or I don't, I
Right.
know she had like this UTI and pyelo and like all of this, so it was very confusing.
Yeah, and that's not typical of septic shock to be like that. Like
Right,
the voluminous
yeah,
diarrhea,
Right. So it was very.
massive vomiting.
And she
That's
was mottled in
Yeah,
blue,
so they
and
initially said it was because of the Raynaud's that she looked so mottled, but it was like extreme mottled.
No.
yeah, like her lips. were
Raynaud.
blue.
No.
Right.
Raynaud's is just.
Yes.
Yes.
Everything.
No,
I agree with
she was
you.
Mottled
She was
everywhere.
modeled everywhere,
So
right?
we had absolutely no idea. Like no one knew what was going on.
Right. Well, after the fact, it was Group A streptococcal toxic shock. So the urine culture was positive for Group A strep pyogenes, and the blood cultures were also positive for strep pyogenes. So this was toxic shock syndrome. I mean, this is kind of classic. We'll go over that. So, toxic shock syndrome is a complication of invasive Group A streptococcal infection. What happens is there's the streptococcus has endotoxins that get released, and then that causes a slew of inflammatory cytokines that get released, and you get that, what you saw. So it occurs in up to about 1/3 of invasive Group A strep infections. A very early onset of shock and organ failure, typically with tachycardia and hypotension. 20% of patients have an influenza-like illness prior to, with fever, chills, myalgia, nausea and vomiting, and diarrhea. 10% have a rash. Does she have a rash coming in? No, right? Okay. Here are the clinical criteria. You have hypotension with a systolic blood pressure less than or equal to 90 in adults, and then 1 or 2 or more of the following: either renal impairment, coagulopathy, liver involvement, ARDS, and soft tissue necrosis. So she had renal impairment, she had renal failure coming in. She had coagulopathy, although not less than 120,000, but she did have, she had thrombocytopenia. She definitely had ARDS. So no evidence of soft tissue necrosis, but sometimes people with Group A, they get necrotizing fasciitis and then develop toxic shock syndrome. So again, this is very similar to gram-negative septic shock from endotoxin. So these toxins that are on the bacterium, either the E. coli or other gram-negatives or Group A strep, their release in the body just causes such overwhelming inflammatory cytokine release that causes all that. So it's just there's a lot of virulence factors of the Streptococcus bacterium that then like the phagocytes can't eat it, and all these things that are with the Group A strep bacterium itself. And then once you get the cytokines, it's just the body goes haywire, and then you get this inflammatory cascade that causes end organ damage. You get shock, you get ARDS, diarrhea, vomiting, all the things that we saw. I mean, she really had classic presentation of toxic shock syndrome. So if there's a necrotizing soft tissue infection, you definitely want to debride it, right? You want to get rid of the infection as best as you can. Antibiotics, so usually it's clindamycin plus vancomycin plus either imipenem, meropenem, or piperacillin tazobactam. Then, if you recognize it, you should give IVIG. 1 gram per kilo on day 1, and then 0.5 gram per kilo on day 2 and 3. In this case, unfortunately, she didn't make it. Like, she didn't make it in time for us to recognize this was toxic shock syndrome, for us to even give IVIG. Unfortunately, she passed away so quickly.
So, random question. In her case, because she was already immunocompromised, would IVIG, in theory, if could it be given earlier in someone that has known
Maybe.
Immunocompromised
Maybe.
patient?
Maybe, right? I don't think anyone was thinking toxic shock
No, I
syndrome,
don't think in
but
this case it would have been recognized, but
maybe. And I
In
bet
theory.
in theory, you're correct. And I bet you she deteriorated so quickly because of her immunocompromise. I mean, you need an intact, even when patients come in super sick, you need an intact immune system to fight off infection. Even if you get septic shock, you still need an intact immune system. If you don't have an intact immune system, it's over. I mean, you just cannot fight off the infection. And unfortunately, her shock was just so profound, it caused PEA arrest multiple times, right?
What was she immunocompromised from?
So she took mycophenolate and hydroxychloroquine for mixed connective tissue disease.
yes.
Yeah, mixed connective tissue disease. So she was on Cellcept. It's not as bad like as methotrexate or prednisone or anything, but Cellcept is still immunocompromising, right? It's still a chemotherapy drug. And then supportive therapy, vasopressors, fluids, mechanical ventilation, as appropriate. So mortality, it's up, 30 to 79% in this case. It's very, very high, very, very high mortality. And then if there are close contacts, you should give them post-exposure prophylaxis. I don't know what happened in this case, but there should be post-exposure prophylaxis of close contacts with either clindamycin or azithromycin. Like, I think I remember reading 10 days of clindamycin or 5 days of azithromycin for the close contacts.
Wow.
Yeah. I mean,
And that's if
group.
it's stimulated, or that's
I think it's just any group A strep infection, and her, which was unusual. Her group A strep was in the urine.
right.
But when you're immunocompromised, man, all bets are off, right? Unless she had a necrotizing soft tissue infection that was missed, that no one could see. I don't know. Unfortunately, she deteriorated so rapidly that it was only after the fact that we picked up, oh my God, that this is group A strep, toxic shock syndrome. You remember the classic story of the retained tampon, and then several days later, that's the classic, the board question they love to test us on. It's the same kind of thing, right? But in this case, it was just in the urine. She became bacteremic, and again, once you become bacteremic with immunocompromise, it's very, very hard to come back from it.
I almost wonder if that's what happened,
Yeah,
right?
she was
Prior to
menstruating,
her
wasn't
admission.
Oh, she was menstruating.
Yeah, but I feel like, doesn't that tampon have to be in for like
Usually has to be in for a long time.
a long
But
time? So
you
she
know
was.
the time where it gets like lost in there. I mean, like people.
Sometimes it gets lost, or it gets forget about it. But then when you're immunocompromised, all bets are off. It's like anything, and it's very. It was very. I looked to see if urine. They didn't even mention urine as a source. You can get bacteremia, but then that's invasive. But you don't like. In her case, there's urine too, which is unusual. You don't usually get group A strep UTI.
That's what I
But-
wondered if it was related to the classic, like, tampon left in place,
Uh-huh.
long story.
Possible. Yeah, it's possible. So.